Welcome to the Hospital Medicine Unplugged podcast.
Today we're diving deep into small bowel obstruction, SBO. It's a really common issue, a surgical emergency we see all the time in acute care, and honestly, it can be quite time sensitive.
Right. Our goal today is to really get into the weeds on diagnosis, how we classify SBO, and, importantly, the evidence behind how we manage it. We want to go beyond just the textbook stuff.
Yeah, really focusing on the clinical thinking you need when things are moving fast.
And the reason this is so critical, well, the numbers speak for themselves, don't they?
They really do. SBO makes up about, 15% of acute surgical GI admissions? That's huge. It translates to maybe 350,000 hospitalizations every year, just in the U.S.
And the mortality, people often hear maybe 10% overall, but that number hides a lot.
But it absolutely does. Because if things get complicated, strangulation, necrosis, perforation, that risk jumps dramatically. We're talking 30% mortality, sometimes even higher.
So our whole focus in the hospital is preventing that leap, identifying the risk early.
Exactly. Preventing that complication. Yeah. And to do that, we first need to understand, well, what's actually causing the blockage?
And when you look at the causes, there's one that just dominates.
Overwhelmingly, yes. Postoperative adhesions, these fibrous bands that form after someone's had surgery in their abdomen or pelvis, they're the culprit in, 60 to 75% of cases.
So that first question, have you had surgery before, is just fundamental.
Absolutely fundamental. And we even know certain surgeries carry a higher risk, right? Like big colorectal surgeries, some GYN procedures, maybe even open appendectomies back in the day. More handling means more risk.
Okay, so adhesions are the main player, but we can't forget the other causes, especially if that surgical history isn't there.
Right. You always have to keep hernias in mind, particularly incarcerated or strangulated ones. That's maybe 10% or so.
Okay.
Then you have neoplasms, tumors, either primary small bowel ones or metastatic disease spreading there. That's another, say, 5 to 13%.
And inflammatory causes.
Yes. Things like Crohn's disease causing strictures, or maybe complications from prior radiation therapy. That accounts for another 5 to 7%.
But let's talk about that situation, the virgin abdomen, where there's no prior surgery. How does that change your thinking?
That's a huge clinical distinction. Because while, yes, you can technically get adhesions without surgery, maybe from inflammation or something congenital.
Right.
The odds shift. Malignancy, internal hernias, which are really dangerous, or less common things like Bizors, they become much more likely. Your suspicion has to go up for those things.
So in that virgin abdomen scenario, maybe that period of just watching and waiting, the non-operative management, should be shorter, a lower threshold for getting surgery involved early.
I think that's exactly right. You just can't afford to sit on a potential internal hernia or a hidden tumor for too long. The stakes feel higher when adhesions aren't the obvious answer.
Okay, so let's shift to the pathophysiology. Once that blockage happens, what's the sequence of events?
Well, it's a cascade, really. The blockage stops things from moving forward. So proximal to that point, stuff starts backing up.
And what is that stuff exactly?
It's primarily swallowed air, mostly nitrogen, but also a ton of fluid. Gastric juices, bile, pancreatic secretions, intestinal fluid itself. The small bowel makes liters of fluid a day normally.
Wow.
So all that fluid and gas builds up, and the bowel starts to dilate proximal to the blockage. Quite significantly.
And that dilation, that stretching, starts affecting the bowel wall itself.
Precisely. The pressure inside the lumen starts to rise. First, it gets high enough to squeeze off the low pressure outflow of the lymphatics and the veins in the bowel wall.
Okay.
So the wall gets congested, edematous. Fluid starts leaking into the bowel wall, into the lumen itself. This is third spacing on a massive scale. A patient can lose 5 or 6 liters of fluid into their gut over a day or two.
So they get dehydrated incredibly fast, even if they're not vomiting much yet. It's all happening internally.
Exactly.
Yeah.
And if that pressure keeps climbing maybe past 25 or 30 millimeters of mercury, it overcomes the arterial inflow pressure.
And that means ischemia, lack of blood flow.
That's the critical point. The bowel wall isn't getting enough oxygen. And this stasis, combined with ischemia, well, that leads to the really dangerous part.
Bacterial translocation and sepsis risk.
That's the cliff edge. The stagnant fluid is a breeding ground for bacteria, especially gram-negatives and anaerobes. When the wall gets ischemic, the barrier breaks down. Those tight junctions between the cells fail.
Right.
And bacteria, they're toxins, they can leak across the damaged wall into the bloodstream, into the lymphatics. That triggers CRS, sepsis. It can happen fast, which is why classifying the SBO accurately is so vital.
Okay, let's talk classification then, because how we label it really drives what we do next. There's a spectrum, right?
Mechanically, yeah.
Mm-hmm.
We usually talk about partial versus complete.
So
Partial or incomplete means the lumen's narrowed, but not totally blocked. Some gas, maybe some liquid, can still squeak through. Clinically, these are often the patients who might still be passing some flatus, gas, even if they haven't had a bowel movement.
And these are more likely to get better without surgery.
Generally, yes, a much better chance of resolving with non-operative management.
Okay, and complete SBO.
That means total blockage. Nothing's getting through. These patients usually present more acutely, more pain, significant distension, and what we call obstipation. They can't pass stool or flatus.
Makes sense.
But while partial versus complete tells us something about the likelihood of conservative management working, the really critical distinction, the one that dictates urgency, is vascular. Simple versus strangulated SBO.
This is the key decision point, isn't it? Medical emergency versus potential surgical catastrophe.
Absolutely. Simple SBO means there's a blockage, but the blood supply to the bowel is still intact. It's perfused. That gives us a window, potentially, for that non-operative trial.
But strangulated.
Strangulated SBO means the obstruction is also compromising blood flow. Ischemia is happening or about to happen. Necrosis, perforation, that's the immediate risk. This needs surgery urgently.
The challenge, though, is spotting that transition from simple to strangulated. It's not always obvious initially. What signs should make us really worried?
You have to be incredibly vigilant. The classic warning sign is a change in the pain, that intermittent colicky pain from peristalsis fighting the blockage. If that becomes severe, constant, unrelenting pain, that's really concerning for ischemia.
Okay, constant pain. What about systemic signs? Vitals, labs.
On exam, the absolute red flag is peritonitis. Guarding, rebound, tenderness, rigidity. If you feel that, surgery needs to be consulted immediately, period.
Got it.
Systemically, look for fever, look for significant tachycardia, that fast heart rate, high white blood cell count, especially with the left shift, and critically, metabolic acidosis. Often the first sign of that is an elevated serum lactate.
Now, about that lactate, we need to be a bit careful, right? A normal lactate doesn't completely rule out trouble.
That is such an important point.
Yeah.
An elevated lactate is very worrying, strongly suggests ischemia, but a normal lactate, especially early on or in specific situations like a closed-loop obstruction, does not mean everything's okay.
Explain the closed-loop issue again.
Right, so a closed-loop obstruction is where a segment of bowel is blocked at both ends. Think of a twisted loop, maybe from an adhesion or an internal hernia. That trapped segment can become ischemic, even necrotic, very quickly. But because it's sealed off, the systemic signs, like lactate elevation or even severe sepsis, might be delayed until it perforates.
So you can have dead bowel sitting there, but the lactate is still normal initially. Relying solely on that number is dangerous.
Extremely dangerous if the clinical picture is suspicious. You have to integrate everything.
Okay, let's walk through the initial workup. The clinical presentation, we know the classic 4 symptoms, but are there atypical ways SBO can present?
Definitely. The classic quartet is abdominal pain, nausea, vomiting, distension, and constipation or obstipation. But think about, say, an elderly patient. They might just present with confusion, maybe some mild distension, not the dramatic picture.
Right.
Or someone on chronic opioids. Their pain perception might be completely altered. They could have strangulation happening almost silently. You need a high index of suspicion in certain groups.
And the vomiting itself can give clues, right? The timing and character.
For sure. If the blockage is high up and the jejunum, patients tend to vomit early, profusely. It might be bilious, and they might not have much dissension initially.
Okay.
But if the obstruction is more distal, down in the ileum, the vomiting comes later. It might be larger volume, and eventually it can become feculent, smelling like stool as bacterial overgrowth happens.
Yeah.
And the distension is usually much more pronounced. So asking about the type and timing of vomiting is really important.
Good point. Now, the physical exam. We talked about checking for peritonitis. What else are the priorities?
Assessing their volume status is key. Look for signs of dehydration, hypotension, dry mucous membranes, poor skin turgor, and again, that persistent tachycardia. That's often one of the earliest signs of significant fluid loss.
And bowel sounds. People always ask about bowel sounds.
You listen, of course. Early on, they might be high-pitched, tinkling, hyperactive. It's a bowel trying to push past the blockage. Later, they can become hypoactive or totally absent, suggesting ileus or maybe late ischemia. But honestly, bowel sounds are notoriously unreliable, neither sensitive nor specific. Don't hang your hat on them.
Okay, and we absolutely have to check for hernias.
Cannot skip that.
Yeah.
A thorough check of all the potential spots, inguinal, femoral, umbilical, any prior incision sites. If you find a tender, irreducible bulge there, you've likely found your cause, and it needs urgent attention. Document tenderness and distension carefully, too.
Right. Let's move to labs. What are the essential initial tests?
The chemistry panel is probably number one initially. Because of the vomiting and the third spacing, these patients get really significant electrolyte problems.
Like what specifically?
Classically, you see a hypokalemic, hypochloremic metabolic alkalosis, especially if they've been vomiting a lot of stomach acid, low potassium, low chloride. You have to check and aggressively replace potassium and manage sodium and fluids. These imbalances can cause arrhythmias, worsen ileus.
Makes sense. And the CBC?
Yeah, standard. You look for a high white count, maybe that left shift, suggesting inflammation or infection. But again, context is key. A normal white count doesn't rule out strangulation, especially in older or immunosuppressed patients. And mild elevation could just be from dehydration.
So you interpret it alongside the lactate and maybe a venous blood gas?
Exactly. The VBG can show metabolic acidosis. And that elevated lactate remains probably the strongest lab predictor that something bad, like ischemia, is happening and needs immediate surgical attention.
Okay, now imaging. We know it's the key decision maker. Plain x-rays used to be the first step.
Yeah, and they can sometimes show you the classic dilated loops of small bowel, usually defined as over 3 centimeters, maybe those air fluid levels in a stepladder pattern. Useful for a quick look sometimes.
But limited.
Very limited sensitivity, maybe 50 to 80%. And crucially, they tell you almost nothing about the cause or, more importantly, the vascular status of the bowel. They miss the critical information.
Which brings us to the CT scan. Contrast enhanced CT of the abdomen and pelvis, that's the gold standard now.
Unquestionably.
Yeah.
Sensitivity and specificity are both up in the mid-90s% range. It tells us where the blockage is, that transition point. It often tells us why adhesions, hernia, tumor, and most critically, it helps us look for signs of strangulation or ischemia.
Let's focus on those CT signs that really scream danger or need for surgery. What should we be looking for?
Okay, first is identifying that clear transition point where you see dilated bowel suddenly collapsing down to normal or decompressed caliber. That confirms the mechanical obstruction.
Right.
Second, signs of a closed loop obstruction. This might look like a C-shaped or U-shaped loop of dilated bowel, or sometimes you see the whirl sign, where the bowel and mesentery are twisted. That's very high risk for strangulation.
And what about the bowel wall itself? How does ischemia show up?
Lack of enhancement is a big one. After Famave contrast, if a segment of bowel wall doesn't light up as brightly as healthy bowel nearby, that suggests poor blood flow. Reduced wall enhancement.
Okay.
You might also see thickening of the bowel wall, maybe submucosal edema giving a target sign or halo sign. That suggests inflammation or congestion, often preceding or accompanying ischemia. And mesenteric edema or haziness around the affected loop is another bad sign.
What about that small bowel feces sign? Is that related to ischemia?
Not directly ischemia, no, but it's important. It means you see particulate stuff mixed with gas bubbles within the dilated small bowel, looking like stool. It indicates significant stasis, usually implies a more distal, high-grade blockage, and it predicts that non-operative management is less likely to work.
Got it. And free fluid. Does the matter?
Yes, a small amount of free fluid can be reactive, but a large amount, say over 500 milliliters, is concerning. It might be exudate from severe inflammation or ischemia or even frank pus if there's been a perforation.
Okay, so we have the diagnosis. We've assessed the severity with the CT. Now, management. No matter what, resuscitation comes first.
Absolutely, the first priority. These patients are volume depleted. Aggressive 5E fluids are essential. Balanced crystalloids like lactated ringers or plasmolite are generally preferred over normal saline, especially in large volumes, to avoid hyperchloremic acidosis and manage the electrolyte issues better.
But monitor closely, especially if they have heart failure or kidney issues.
Of course. Careful monitoring of urine output, vital signs. Then, NPO nothing by mouth, bowel rest. And crucial, nasogastric decompression.
Tell us again why the NG tube is so important.
It does several things. One, it removes gas and fluid building up, which lowers the pressure inside the bowel. That might improve blood flow to the wall, potentially reducing ischemia risk. Two, it makes the patient feel much better, less pain, less nausea, less vomiting. And three, It significantly cuts down the risk of aspiration, which is critical if they need anesthesia or even just during transport.
And while fluids are going in, we're chasing those electrolytes, replacing potassium, checking sodium.
Continuously. Frequent checks, maybe every 4 to 6 hours initially, until things stabilize. You can't let significant hypokalemia linger.
Okay. Now, for the patient who comes in, looks stable, no signs of peritonitis or sepsis, and the CT shows a simple SBO, likely adhesive, non-operative management, or NOM, is the usual first step.
That's right. Continued for V fluids, NG decompression, bowel rest, close monitoring, waiting to see if the blockage resolves on its own.
But the waiting isn't indefinite. We talked about that time limit.
Yes, the 72-hour rule. That trial of NOM really shouldn't go beyond 72 hours.
Why is that cutoff so widely accepted? What's the evidence?
It's based on studies looking at bowel injury over time. After about 3 days of persistent, significant obstruction, the risk of irreversible damage transmural necrosis really starts to climb. The mucosal injury becomes full-thickness injury. And data consistently show that if NOM fails and you delay surgery past that 72-hour mark, patients have higher complication rates. They're more likely to need a bowel resection, longer hospital stays, higher morbidity overall. It's a well-established inflection point.
Which makes the use of water-soluble contrast agents like gastrografin so interesting. They can help speed up that decision-making process.
They're a really valuable tool, yeah. They have both diagnostic and therapeutic potential. Usually after maybe 6 to 12 hours of initial decompression and stabilization, you give the contrast, often down the NG tube.
How does it work therapeutically? What's the mechanism?
It's hyperosmolar, very concentrated. So when it gets into the bowel lumen, it pulls a large amount of fluid into the gut, both from the circulation and from the swollen edematous bowel wall itself.
Okay.
This fluid influx does two things. It can decrease the bowel wall edema, making it less stiff. And the increased volume, this liquid bolus, can sometimes create enough pressure to push through a partial blockage or loosen adhesions. You can sort of hydrodissect the obstruction in a way.
And diagnostically, how does it help us decide?
You follow its progress with x-rays.
Yeah.
Typically get one around 4 to 8 hours, maybe another 24 hours. If you see that contrast has made it into the colon by, say, 24 hours, that predicts with very high accuracy over 90% of the SBO will resolve without surgery.
And if it hasn't moved?
If the contrast is still stuck in the small bowel after 24, maybe 36 hours, that's a strong predictor that NOM is going to fail. It helps you make the call to go to the OR sooner rather than waiting the full 72 hours only to fail. It accelerates the decision pathway.
Okay. So let's say NOM fails, either the patient gets worse or the clock runs out or the contrast doesn't pass. What are the absolute clear-cut reasons to call surgery immediately?
The triggers should be pretty clear. 1, any sign of clinical deterioration, worsening pain, especially that constant pain, development of sepsis signs, fever, worsening tachycardia, maybe altered mental status, hemodynamic instability that's not responding to fluids. 2, objective evidence of a complication. Peritonitis on exam is numero uno. Or if repeat imaging shows clear signs of ischemia, like non-enhancing bowel, pneumatosis, gas in the bowel, or a definite closed loop that wasn't clear before.
Right.
And 3, failure of that NOM trial after 72 hours. Even if the patient seems stable, if the obstruction hasn't resolved by 72 hours, the risk of delaying further outweighs the benefit of waiting longer. Time's up.
When surgery is the decision, what's the approach usually? Laparoscopic versus open?
It depends. For selected cases, stable patients, likely simple adhesive SBO, not too much bowel distension, laparoscopy is often preferred. It generally means a shorter hospital stay, fewer wound complications, faster recovery.
But not always possible.
Not always. Open laparotomy is still the standard for complex situations. If the patient's unstable, if there's strong suspicion of widespread peritonitis or perforation, if the bowel is massively dilated, making laparoscopic visualization impossible, or if you anticipate needing a significant bowel resection, then open surgery is safer and necessary.
And throughout this whole process, from presentation to decision, it really highlights the need for close teamwork.
Absolutely essential. SBO is fundamentally a surgical problem. The surgeons drive the diagnostic workup, interpret the imaging critically, assess the severity, and ultimately make the call about operative timing and approach.
And the medical team, hospital medicine.
Our role is crucial support. Managing the aggressive fluid resuscitation, correcting those tricky electrolyte problems, potassium, sodium, etc., managing the patient's other medical issues, monitoring closely for any subtle signs of deterioration, watching kidney function. It's true co-management of an acute dynamic process. We have to be on the same page.
Let's talk outcomes. What are the big complications we're working so hard to avoid?
Well, the catastrophic ones are bowel ischemia, leading to necrosis, then perforation, which causes peritonitis and sepsis. Those are the immediate life threats.
But there are significant medical complications too, right? Even if necrosis is avoided.
Definitely. Severe dehydration itself can cause problems. Those electrolyte disturbances, especially low potassium, can be dangerous. And acute kidney injury, AKI, is really common, just from the massive fluid shifts and poor perfusion. These need proactive management alongside the obstruction itself.
We keep saying time is critical. Is there data showing how much delay matters?
Oh yes. Studies clearly show that if surgery is needed, delaying it, especially beyond 24 hours from presentation when strangulation is suspected or confirmed, leads to significantly higher rates of complications, more bowel resection, and increased mortality. Prompt intervention saves bowel and saves lives.
So, to help synthesize all this, the clinical picture, the labs, the imaging, there are predictive scores out there. Can you give an example, maybe using the Wasmer score, of the factors that help predict severity or the need for surgery?
Sure. Scores like the Wasmer model try to integrate multiple factors. Things like age, being older, say 70 plus, is often a risk factor, maybe due to less physiologic reserve or atypical presentations. Whether it's their first episode of SBO is also relevant. First-timers might be more likely to have a non-adhesive cause like a tumor.
Okay. And clinical signs.
Specific findings carry weight. Not having had a bowel movement for, say, 3 days or more suggests a pretty complete blockage. And abdominal guarding on exam is a strong predictor of underlying trouble. From the labs, a high CRP, maybe over 50, indicates significant inflammation, more than just simple obstruction.
And the CT findings in these scores?
Those are usually the heavy hitters, definite lack of contrast enhancement in the bowel wall, the presence of that clear transition point, signs of that closed loop, and a large amount of free fluid, like we mentioned, over 500 cc's. Putting all these together, the clinical exam, the labs like lactate and CRP, and these specific CT findings helps quantify the risk and reinforces the urgency when needed, helping us stick to that 72-hour maximum for NOM if things look okay initially.
This has been a fantastic, really practical deep dive. So if we had to boil it down, what are the absolute key takeaways for listeners managing SBO?
I think number one is rapid stratification. Don't just stop at SBO. Is it simple, or is it potentially complicated or strangulated? That's the immediate question.
And CT is the key tool for that.
CT is central. It guides that stratification and tells you about the cause and potential ischemia. Number two, for those stable patients without red flags, NOM is reasonable.
Right.
But it must be time limited. That 72-hour window is critical. Don't push past it if the patient isn't improving.
And number three, consider using tools like water-soluble contrast. Gastrographin can help you make that decision faster, either confirming likely resolution or signaling the need for earlier surgery, potentially avoiding that progression to necrosis and its offer mortality rate.
Exactly. Timely intervention, whether it's surgery or therapeutic contrast, is paramount.
Okay, before we wrap up, maybe a final thought for people to chew on, something looking forward.
Well, we spent all this time talking about managing SBO, mostly caused by adhesions. So the provocative thought is about prevention. Since adhesions are far and away the biggest cause, what's the role, and maybe what should be the role, of strategies aimed at preventing them in the first place, or preventing recurrence? Things like adhesion barriers used during surgery, maybe specific minimally invasive techniques, even potential medications. How actively should we, as the physicians often managing the consequences of adhesions, be involved in pushing for and understanding prevention? That seems like a major frontier for actually reducing the burden of this disease long term.
That's a really important point, thinking upstream. Excellent food for thought. Thank you so much for walking us through all of this today.
My pleasure. Thanks for having me.
And thank you all for joining us on this deep dive.